everybody. Welcome to this Exchange webinar. This is the second of the webinars for the Safeguarding Older People conference series, so welcome to that. Today's session, I'm joined by three presenters who will introduce themselves in more detail in a minute, but they are Jeremy Dixon, Asri Maharani and Rina Lazzarado. As I say, they will introduce themselves. The focus of today's session is safeguarding people living with dementia and social care, health and third sector responses to abuse and neglect of those living with dementia. Obviously, by definition, the session will focus on abuse and neglect, and obviously just to make people aware that there will be content which will be sensitive. The presenters are hopefully going to present for around about 45 minutes, and then there'll be questions and answers at the end, which will be chaired by me. So what I would ask is that if you have a question that you would like me to ask on your behalf at the end of the session, can you please put those into the Q&A tab at the top of your screen? The chat is also open if you want to make comment or share things with other attendees. But can I ask you, if you have a specific question that you would like me to ask, that you put that into the Q&A box, because apart from anything else, it makes it easier for me to identify questions in amongst all your comments and discussions. So Q&A box for questions, any general comment or discussion or anything that you want to share with other attendees in the chat, please. And on that note, I'll hand over to our presenters.
Thank you, Martin. Good afternoon, everyone. My name is Rina Lazzarado. I'm a research fellow at the University of Manchester and also practicing best interest assessor and a social worker. So that's me. Jeremy?
Hello, everybody. My name is Jeremy Dixon. I'm a reader in social work at the Centre of Adult Social Care Research at Cardiff University.
Asri?
Yes, and hi everyone. My name is Asri Maharani. I'm a lecturer in Division of Nursing, Midwifery and Social Work at the University of Manchester.
Thank you. So I will start with the initial bit of the study. Thanks, Asri. So today we'll be talking about our research on safeguarding people living with dementia. So this work explores how health and social care professionals conceptualize and respond to risks of abuse and neglect, and how partnership working happens in practice. Next slide, please. So here's what we'll cover. So we'll start with the background and rationale for the study, followed by various phases of the study discussing aims, methods, and findings. And at the end, we'll have questions. So I will talk about phase one. My colleague, Dr. Asri Maharani, will discuss phase two, and Dr. Jeremy Dixon will talk about phase three. Next slide, please. Safeguarding is everybody's responsibility, and CARE Act makes it a statutory duty for local authorities and partner agencies. Section 42 of the CARE Act stipulates that where an adult has care and support needs, is at risk of abuse or neglect, and cannot protect themselves, the local authority must make necessary inquiries to decide on protective action. So how is this relevant for people with dementia? People living with dementia face higher risks of abuse and neglect due to cognitive and communication challenges. Globally, up to half of people with dementia experience some form of abuse or neglect, and this often occurs in their homes or care facilities. Also, they might struggle to recognize or report abuse, and carers may endure it due to emotional or social pressures. There is wider research on types of abuse, settings in which they occur, and risk factors, but limited information is available on how safeguarding operates for people living with dementia and outcomes of the safeguarding, especially the role of primary and social care professionals and how they work together in identification and prevention. Hence, our study aims to explore how safeguarding works in practice for people with dementia, focusing on how professionals understand their legal responsibilities, collaborate across services, and respond to concerns of abuse or neglect. Next slide, please. The next one, please. So in phase one, we conducted a literature review using a realist method to find out what works, for whom, and in what contexts. So who are the key stakeholders? What are their roles? How partnership working happens? How professionals conceptualize risk, abuse, neglect, and also how they apply the law. Next slide, please. So throughout the study, we consulted with 3 PPI groups. So these included people living with dementia, family carers, police officers, people with disabilities, social workers, and GPs. So they helped to refine the program theories, interpreting the context mechanism and outcomes frameworks and their configurations, and offering critical reflections by drawing on their own experience. So for the review, we screened about 6,194 articles from 5 databases for those published between 2014 and 2024, written in English, conducted in England, and focused on dementia safeguarding, including related themes of abuse and neglect. So at the end, we included 44 articles that met our criteria. So we extracted data that provided contextual information, example, policy environment, organizational settings, demographic variables, and under mechanisms, we explored all the training and resources that were used, what were various stakeholders' responses to these, stakeholder roles, and interagency pathways. And finally, the outcomes included the results. So we analyzed all of these data using NVivo and Excel. Next slide, please. So what our findings show is that safeguarding people living with dementia is not straightforward. It's a complex and multi-layered process that's shaped by the progressive nature of dementia, the impact of cognitive decline, the type of care setting, and the different roles played by both family members and also the professionals. So a number of contextual factors influence how effective safeguarding can be. So these include the vulnerabilities experienced not only by people living with dementia, but also by care staff, the challenges that come with maintaining professional boundaries, the risks that arise when people refuse care, the culture within institutions, and wider gaps in training and policy implementation. So all of these factors create real tensions between protecting people, respecting their autonomy, and recognizing when they may be at risk. So safeguarding often involves navigating the balance between intervening and upholding the rights and wishes of persons living with dementia. Our findings also emphasize that effective safeguarding relies on coordinated work across a wide range of stakeholders, including health and social care, legal services, and financial institutions. Social workers, police, advocates, healthcare professionals, and other agencies each play critical roles. For example, social workers often lead on capacity assessments, best interest decisions, and overall safeguarding coordination. Police teams typically respond to emergencies or criminal concerns related to abuse or neglect. And advocacy is also essential. So independent mental capacity advocates, independent domestic violence advisors, lasting power of attorney arrangements, and court-appointed deputies all help ensure that voices of people living with dementia are heard and their rights are upheld. A key issue we found is that there are no clear boundaries around what counts as acceptable or unacceptable care in dementia settings. Because these thresholds are unclear, and harmful practices can become normalized. So things like locking someone indoors, forcing care, or speed feeding are sometimes mistaken as protective rather than recognized as abusive. In some care environments, these behaviors even become routine, and people may use softened language to describe them, so which masks their severity. So this highlights the need for a cultural shift so that abuse and neglect are recognized and reported early. So there are also major challenges in how abuse is defined. Families, carers, and professionals often interpret the same behavior differently, so which creates inconsistencies and makes staff unsure about when to report concerns. Even though the CARE Act provides guidance, interpretation varies depending on training and also the circumstances. Finally, stigma and fear often prevent people with dementia and their carers from reporting abuse, whether due to embarrassment, fear of retaliation, or not being believed. So issues of self-neglect and cultural differences add further complexity. All of this highlights the need for clearer communication, better training, culturally sensitive safeguarding approaches. Next slide, please. So under the CARE Act, safeguarding follows 4 stages. So identifying concerns, carrying out Section 42 inquiries, developing a plan, and reviewing outcomes. So some of the barriers identified in the review include poor training, communication breakdowns, and underrepresentation of diverse experiences. We also see that harmful restrictive practices can become normalized in care settings, which delays recognition of abuse. Coercive control and misuse of legal powers like LPAs make situations even more complex, especially where there's financial abuse or isolation. During inquiries, cultural beliefs, secrecy, and mistrust of services can limit engagement, particularly when dementia is poorly understood. Our review highlighted effective safeguarding requires legal literacy and interagency collaboration. So failures often stem from siloed practices and role confusions. So best outcomes are not limited to procedural adherence, but in coordinated systems that prioritize human relationships, ethics, and cultural competence. Strong communication, trust between agencies, and clarity about responsibilities also lead to earlier identification, better coordination, and safe outcomes for people living with dementia. Poor training, underfunded services, and role confusion, on the other hand, increase the risk of harm and safeguarding failures. So next slide, please. So what does this mean for practice, policy, and research? For practice, safeguarding needs to be embedded into everyday care and not just activated during crisis. Professionals need support to balance risk and autonomy, especially when capacity fluctuates or when there are coercive dynamics. Training should go beyond basic compliance and include relational ethics, cultural competence, and practical legal literacy around Mental Capacity Act and CARE Act. For policy, current frameworks often rely too heavily on formal reporting thresholds and don't adequately account for structural inequalities. So policies need to be more inclusive and culturally responsive, with better investment in advocacy services and proper resourcing for oversight bodies like CQC and Safeguarding Adult Boards. For research, there is a need to explore intersectionality, co-produce solution with people living with dementia and their families, and also conduct longitudinal studies. Next slide, please. So this review provided a theoretical framework for understanding various mechanisms at play in safeguarding in the context of dementia. So it emphasized that safeguarding is contextual, relational, and complex. So legal frameworks provide structure, but human connections drive success. So we need coordinated, rights-based, relationship-based systems that center around equity and lived experience. So thank you for listening to me. Now I will pass you on to Dr. Asri Maharani, who will talk through phase 2 of the project and the findings from that phase.
Yeah. Thank you, Rina. So I would like to present on the quantitative findings in the phase 2 from our research. Yeah. So as we know that safeguarding among older adults with dementia is a growing concern at this moment. However, there is not yet any national evidence on how safeguarding activity varies by geography, by times, and demographic characteristics. So this phase aim to examine the geographical and temporal distribution of safeguarding concerns and inquiries among older people with dementia in England. And specifically, we're looking at the trends over time from 2015 to 2022 in safeguarding concerns and inquiries in England. And we will also looking at demographic differences by age and sex and regional variation across local authority districts. We need to be a bit in mind when explaining or interpreting the result, because we are not looking at the causality or relationship at this moment, but we would like to describe the safeguarding activity, where is it concentrated and how has it changed over time, to inform more on the dementia and safeguarding literature. For the study design, this is a population-based quantitative analysis. We use secondary national data sets from 2015 into 2022, which focus on safeguarding concerns and inquiries involving adults with dementia in England. We use 3 data sets. The first one is NHS digital data sets on safeguarding adults collection, or SAC, which has the records of all safeguarding concerns and Section 42 inquiries by local authorities. The second data that we use is NHS Digital also, recorded dementia diagnosis in 2022. It provides dementia prevalence by age and sex from GP records. Well, the final data we use is the Office for National Statistics, or ONS, population projection to 2020, which will give us the age and sex population estimates for local authorities. So the limitation of the safeguarding data at this moment is that it's not provide us with individual level data, nor a very specific local authority by demographic or ethnicity or any other demographic and socioeconomic characteristic. So to be able to looking at the prevalence in each of the local authorities and by sex and gender, we use ONS National Census 2020 to estimate it for the local authorities. For the analysis, we use descriptive and spatial analysis using data, and then we map the trend and regional variation across 317 local authority districts here and examine the difference between regions. So for the first here, this slide shows the overall trend in safeguarding activity over time. So we can see here it is from 2015 into 2020. So for the solid line, this is safeguarding concern. The dash here is Section 42 safeguarding inquiries. And then finally, the lowest one with the dots is the other inquiries. So in the left side, it is for all individuals. In the right side, it is for individuals with dementia. And we can see here that they have a similar upward trending. However, and then we can see that from 2015 into 2022, the number of safeguarding concerns are almost doubling here. But among the people with dementia, we also have the similar trajectories. However, there is a little dip here, a notable dip here in 2020 and 2021. It could be due to the disruption of safeguarding pathways during COVID-19 pandemic, but yeah, this is only a plausible explanation on this one. There is probably another explanation. So the second one is we disaggregate safeguarding activity by region. Here we have 9 regions here from northeast into southwest, and then we can see that the highest one is of safeguarding concern is in southeast area, and then also the Section 42 safeguarding inquiries is also highest in the southeast region here. And yeah, so this is from this one we can see that there are quite a lot of discrepancy between region. Similarly, in the individuals with dementia, we can see here, yeah, the highest is east of England and followed by the Yorkshire and the Humber and then the northwest one. But this one is for the 9 region. For the local authority district, we mapped it into the local authority district. We have only the data on England. And if you can see here, there are quite a lot of gray area here because there are missing data. The missing data mostly not because the data is missing, also because if the number of safeguarding concern or number safeguarding inquiries is less than 4, and then the NHS digital will not release the data, because it can be trackable. So that's why we have quite a lot of missing data here. And this spatial maps highlights the local authority level variation here. We can see that there are quite a lot of local authority in this area and in the middle here with a very high safeguarding concern. Similarly, also quite high safeguarding inquiries, which can reach into 775. While in several areas, the one that is blue, for example, here, they have only like less than 35 inquiries here. And then if we would like to looking at by age group and sex here, the total number of safeguarding concern for males with dementia is lower than females. It is around 7,500, while females is higher in 12,600. Similarly, the number of Section 42 safeguarding inquiries is also more frequent among males, which almost doubling also than females, 6,000 and 3,500. Age-related trend shows the estimated safeguarding concern increased significantly with age, peaking at 80 into 84, and then a bit lower in 85 into 89, and then 75 into 79. This pattern also similar in among females, that the highest one is age between 85 into 89. This is similar also for the Section 42 safeguarding inquiries. The highest number of inquiries is for the people around age with an age group around 80 into 84. For males, and then 1,300 for females in the same age group. Yeah, so what's then the interpretation and implication of these results? We can see here that there are significant increases in safeguarding concern and inquiries in England between 2015 into 2022, particularly concerning individuals with dementia. And then we found also a decline, as you can see, for both safeguarding concern and inquiries for people with dementia in 2021. And one of the plausible explanation is that probably there is a disruption in safeguarding pathway and reduced reporting during the lockdown. And then among individuals with dementia, regional patterns are observed. So it is varies among regions, with the higher safeguarding concern reported in a more deprived area. And enhanced advocacy training and data granularity, because I think most limitation is the difficulties of getting of the data are required here. Yeah, and then Jeremy will continue with the third phase of the study.
Thank you very much. Yeah, so I'm going to talk about the qualitative findings, and then we'll open for questions. So next slide, please. So just to give a bit of context about the CARE Act in England. So the safeguarding duties in under the CARE Act match those really of the Social Services and Wellbeing Wales Act, in the sense that there's an expectation that if there's an adult who's got care and support needs and they're unable to protect themselves from abuse or the risk of it because of those care and support needs, then people are encouraged to make a call to the local authorities to indicate that there's a safeguarding concern, and then a safeguarding inquiry can be held. So under the CARE Act, partnership is a key principle under Section 6, and like the situation in Wales, there's a very high emphasis on well-being and trying to prevent lead before it occurs. So if we look at what research has been done focusing on partnership working, there's not very much of it. Rena talked about some of the findings earlier on, but just to highlight a few key issues. Research which has been done into safeguarding adults reviews, so that's where something has gone wrong and somebody has either been killed or there's been serious consequences as a result of a failure of safeguarding. Research which has looked at that, this is a Preston Shute research, identifies a number of problems that have been seen in those reports, and one of those is that there was a lack of multi-agency meetings and low levels of agreement about how risks should be assessed. The study by Daly et al. Is looking at people's views about how financial abuse ought to be dealt with, and it found out that a lot of professionals were saying that they felt that partnership working principles weren't always held, and particularly responses by the police and social services were seen to be inadequate by people who were interviewed. So this is a range of different professionals. The third study by Mason and Evans looks at safeguarding from the point of view of social workers and how they kind of understand the role. And it found that they kind of had an idea in their head about kind of proper roles for what social workers should do. Within that, they saw social workers as having the leadership role. Joint working was seen to be very important in that, partnership working was emphasised, but some conflict was identified, citing disagreements between and changes towards other agencies. Proxy work, in which social workers were delegating other parts of the safeguarding inquiry to other agencies, was seen to be a particularly difficult issue to manage. Next slide, please. And just to mention, while I think of it, the studies that I'm quoting are all of those studies were held in England, and the reason that I've cited them are not Welsh studies is unfortunately that there isn't huge amounts of research in Wales on this topic, so it's quite hard to say what's happening with certainty, really, without just becoming anecdotal about it. So going back to this slide and what we did. So as Rena mentioned, we were interested in partnership working. So when Rena put the bid in, we were saying that we wanted to look at partnership working between local authorities and primary care professionals in particular, but over time we expanded that out a bit to look at voluntary sectors as well. And we were also interested in the views of people living with dementia and their carers. So 37 people were interviewed overall. Of those, 7 were social care professionals, 5 primary care professionals, and 5 from the voluntary sector. There was 2 people living with dementia who came forward. We did try to get much more than that, but it was very difficult to recruit. And we got quite a lot of family carers, about 17, and 1 psychiatrist. So we were interested in who are the key stakeholders, what kind of roles they play, what their understandings of the process was. So we used purposive and snowball sampling, meaning that we went to a number of different agencies who were involved in safeguarding or primary care work and asked for participants through that, did some advertising to get people to volunteer. And we used thematic analysis to look at what was meaningful through the data. And that method of analysis looks for what you call dominant themes, which is the themes that come up most often within the data. So in this presentation, I'm focusing particularly on the issue of partnership working. Next slide, please. So one thing that's been seen in research studies which have been carried out before legislation came in England and Wales was that professionals often said that they felt that partnership working wasn't working very well, or people were quite often unaware of the law and policy which existed. So we saw a difference in our interviews in that everybody tended to think that abuse and neglect were important issues for people living with dementia. So in this quote, a social worker says, abuse could be happening to someone who is suffering from dementia because of vulnerabilities that come with cognitive deficits as a result of dementia. So this type of quote was quite typical. People talked about people living with dementia being particularly vulnerable and being vulnerable to abuse because of people's kind of evil ends, to use one quotation. And I guess one thing to note about this was that when people were thinking about the risk to people living with dementia, they tended to be indicating that people would always be unable to protect themselves. So in thinking about these things, maybe they were thinking about people with middle to late onset dementia rather than the group of people living with dementia more generally. However, safeguarding was viewed by people as everyone's responsibility. And in this sense, our participants were picking up some of the messages which have been echoed in policy about this being an issue that everybody needs to take account of. Next slide, please. So all professionals were positive about partnership working. And again, this sounds like it could be a common sense statement, but if you look at research which had been done maybe about 15 years ago, quite often people weren't necessarily positive about partnership working. So we can see a change in the picture. There were a number of reasons why people felt that partnership working was necessary. So the first was that there was shared expertise across professional groups. So some social workers would say, for instance, if there's a concern being raised because somebody living with dementia has pressure sores, we're not medically qualified. So we really need to work with nursing and health professionals so that they can do an assessment of the risk and what's going on. So it wasn't just about kind of professional expertise. There was also the idea that people who've been working with a person living with dementia over a period of time might have a really good relationship with them, which somebody coming in fresh wouldn't have. So social workers were quite often saying, well, we need to kind of work with those professionals and maybe get them to do the work on our behalf, which we would direct, partly because if we come in and we're new, they won't trust us. It could be very suspicious, or it could be distressing to the person. Secondly, people talked about multidisciplinary working being useful because it provided extra sensitivity. So one GP gave an example where a woman was coming into the practice with her husband. there was some issues with him being drunk and shouting at her. And the GP said, well, none of us really saw that as a potential safeguarding issue or was potential abuse. And it was only when one of the ambulance workers came in and said, is this something we should be thinking about, referring to safeguarding, that we thought, well, actually, maybe it is abuse and neglect, and maybe we need to look at it more carefully. And thirdly, multidisciplinary working was seen as being key to responding to abuse effectively. So identifying who should act and reviewing those plans to make sure that outcomes didn't get lost over time. So next slide, please. So let's move on to thinking about experience as a partnership working. So previous research that I've done into the way that adults safeguarding is done by social workers identified that they tend to see their role as interpreting the law, which if you're a social worker, you kind of think, well, of course you've got to follow the law, but other professionals don't always give primacy to that issue. And this was also kind of seen in the research I mentioned earlier by Mason and Evans. So social work staff emphasised the need to look at the criteria under the Care Act and the Mental Capacity Act. And when thinking about these acts, they weren't always saying that local authority followed the law in the best way. So some social workers were quite critical of the local authority for being quite reactive to need and not necessarily following well-being principles. And other social workers were saying, well, people don't really think about mental capacity in the sense that they are maybe thinking that all people living with dementia lack capacity, and people are saying things like, can't you just detain them under the Mental Health Act, or things along those lines. So that they were the kind of key areas which came up. Tensions with health services were identified around partnership working. So Julie here was talking about tensions with GP surgeries. So she says, it depends on what surgery. They're not consistent. Some are brilliant and some aren't. And that's a lot of chasing to follow up. Some are keen to go out on a visit. Some won't ever go out on a visit. That's difficult, really. So this was a quite common complaint about GP practices by social workers, that sometimes people were very cooperative and other times people weren't. And the issues that were raised was that sometimes GPs could say, well, you've got to get signed consent from people before we can hand over information. And that was seen to be particularly difficult if the person who was being asked to consent was potentially an abuser. Next slide, please. So I mentioned in the last slide that social workers saw their role as being specialists in the law. Primary care staff, when they were interviewed, were saying, well, actually, this is something that we would struggle with. So one GP, when he was asked, what law and policy do you think is important? He kind of said, well, he made a joke saying, well, what law or policy? But other people also said, well, actually, it's difficult for us to keep up with. One GP said, well, it might be easy if you're a mental health social worker or a psychiatrist. They probably think that's dead easy, just get on with it. But if you're doing other work day to day, it's not so easy. And people were saying, well, it's quite difficult to keep abreast of. And they, from their point of view, they felt that the law and policy was changing quite often. So if you looked at the way in which GPs responded to abuse and neglect, quite often they were talking about internal GP policies, such as if a concern comes up, then you speak to the senior GP, for example. When talking about social services responses, to move on to the second point, quite a few felt dissatisfied with that. So a particular bugbear was the kind of time they were given to respond to issues, and the view that they social services didn't always kind of appreciate the pressures that GPs were under to see people in surgery. So Liam here says, we had one referral a couple of weeks ago, actually. They literally invited us 2 hours before the actual meeting. So we're like, what do you want us to do here? So again, there's very few times that I can remember over my 7 years of being here when the safeguarding team have specifically waited for us or made sure that we attended the safeguarding meeting. So in saying this, GPs weren't kind of saying that there shouldn't be emergency situations, but they were kind of indicating that they didn't ever feel that local authorities waited for them or gave them kind of due consideration in the process. Other issues that they raised as being problematic was that they felt that information sharing wasn't very good. Partly that was seen as being systemic in the sense that local authorities and health authorities had different computer systems, so they didn't talk to one another. But beyond that, they also felt that social workers didn't inform them of the outcomes from safeguarding inquiries. And from their point of view, they were saying, well, we want to know what's happened here, or if there's anything that we need to follow up on, and didn't feel that they got that information, or felt that it was quite hit and miss and piecemeal. Next slide, please. So we were only able to recruit 2 people living with dementia, unfortunately, and only one of those was able to talk about the safeguarding. And he said here that I didn't expect them. I didn't expect any of them come to the house. So the police came. There were 2 policemen, one from the mental health team and the solicitor. I didn't expect any of that, and I didn't know what they were doing. So it was difficult for people living with dementia to kind of understand the process and know what was going on. Although one thing to note was that people living with dementia didn't really see themselves as being high risk as a matter of course. You know, they were different from all the other groups in that respect. Next slide, please. So lastly, skipping over to family carers, I've missed out advocates just because of time. So all the family carers in our sample tended to give negative experiences of safeguarding. So generally people were aware that safeguarding was happening somewhere in the background, but they often weren't aware of the details of that. And one of the carers here is quite typical. She says, never once was I able to get through to them, the adult safeguarding team. And some of them in the social services line were saying, leave your name, we'll get back to you. Nobody got back to me, and emailing doesn't work. So people in the sample were saying, well, when we tried to get through, we couldn't reach anybody. And then in addition to that, when safeguarding inquiries were happening, people were also expressing frustration. So Doris here says, I raised the safeguarding issue, I provided the information, and then the investigation was carried out, and that decided. Some recommendations were decided. At no point from me raising the issue to the end result was I involved. There was no involvement whatsoever. So this was typical amongst carers. We didn't see any kind of positive responses to safeguarding amongst this group. Next slide, please. So a very quick summary before we go to questions. So in contrast with research which has been done before safeguarding law coming into effect, professionals are largely positive about partnership working. They see it as a good thing that people ought to be able to work in partnership, and the principles were seen as being the right things. Multi-agency expertise was seen to be useful for responding to safeguarding issues. And as I mentioned before, there was this perception that people living with dementia were particularly vulnerable to abuse and neglect. But some tensions were identified. So social workers identified poor understanding of the law and variable involvement. Primary care practitioners talked about poor levels of notice and information sharing, particularly around outcomes. People with dementia talked about the process being confusing, and carers talked about poor levels of involvement. So in summary, we can see that there's some real improvements in terms of partnership working from what previous researchers told us, but there's still some issues and problems that could do with some resolution. So thank you very much for listening, and I'll hand over to Marty as the chair.
Thanks very much. Well, that's great. Al, thanks for taking your slides down so I can see you better. We've had quite a few questions in the Q&A section, so we've got about 12 minutes. Hopefully with good chairing, I'm going to try and keep us to time and to finish at 2. So we'll see if we can, how many of these we can rattle through. The first one I think is probably aimed at Jeremy predominantly. which I think you kind of covered in your presentation, but just in case you've got any further comments. And it's a question about whether you feel able to reflect on how closely the findings of this work resemble the situation in Wales.
The honest answer is we can't really say that because there isn't comparative research in Wales. I mean, that's a pity, actually, because the way in which statistics are collected in Wales would give the opportunity to collect better results than in England, but so far nobody's done that. So there aren't comparative studies in Wales that we can compare to. I suppose the one thing that might be useful to people to look at is that there's been some research looking at safeguarding adults reviews, which has been done drawing together messages from Wales, but that's not specific to people living with dementia. But I would say the findings from that are quite similar to the findings from England.
Brilliant, thank you. I think as a good chair, I had a question lined up, which actually somebody in the Q&A section has kind of covered, so I'll ask their question rather than mine. There's been a couple of questions which relate to the quantitative findings, so I guess I'm predominantly aiming this at Asri, although the others of you might want to chip in as well. In terms of the findings that you presented, somebody's asked, bear with me, somebody's just covered your question. Has population density been accounted for when looking at the numbers of inquiries made? I.e., are the numbers of inquiries roughly proportional to the population, or do high and low levels of inquiry suggest another issue?
Yeah, so for the inquiries, it's not the one that we provide, it's the number, so it's not the density based on the population.
Okay. And then there's a second sort of quant finding question, which is, are the higher numbers reported not the result of higher incidence of dementia in the group cited, e.g. dementia is more prevalent in women, in females, etc.?
Yes, it is reflecting, the number is also reflecting the higher number of people having dementia, because the issue is the one that I mentioned before. There is no enough granularity in the data, so we don't have like the number of the people with dementia who reporting safeguarding inquiries or concern breaking down by gender. So what we did is like we did estimation based on the number of the people with dementia, which is included the prevalence of dementia by gender. So the higher number of the people with dementia reporting inquiries is also reflecting the higher number of people with dementia among females.
Okay, thank you. There's a question which is about, do you have any data about the number of physical or sexual examinations that have been done as part of adult safeguarding investigation, even a rough idea of the proportion needing actual examination? Also, if there is a protocol for consent, best interest decisions, examination and investigation.
So as far as our understanding, the data is not available. So we don't have the data on the physical examination also. We actually did ask about the data that is in individual level or more granular or other aspect here, but because of the number of the people with safeguarding and then with dementia who have the safeguarding concern inquiries quite small, and then they are saying that it can lead into that they cannot anonymize the person. So yeah, so the data so far is not available.
Okay, thank you. Did most of the people with dementia in this study receive their care at home, in a general care home, or in a nursing home with specialist care for residents with dementia?
Good question.
I will answer that, yeah.
Okay.
So the people with dementia recruited into the study, they were based in the community, lived in their own homes. So we did, at the time of recruitment, we approached a lot more people, but all of them were based in the community, and some of them lacked capacity, and therefore we couldn't include them in the study. The studies included in the review, realist review, some of the studies were conducted with residents in the nursing unit and also in the residential unit. You can go back to the details of the papers that are included in the review from our study. So the reference to our paper should be in the slides somewhere.
Brilliant, thank you. Have either of you got anything else that you want to add before I go on to the next question?
No.
Okay, that's fine. There's a question which is there anything in place to protect individuals with dementia within society, for example, frauds or scams? Also, companies that take advantage of these individuals by talking them into paying for services or items that are not appropriate for them, which is related to financial abuse. So I guess the question is around whether there were instances of financial abuse within the findings of your study.
Do you want to answer that, or should I answer that one, Rena?
So in terms of in the review, there were discussion about what's best practice, but we did not find examples of what a financial institution or a legal firm had done, put in place to prevent such abuse occurring. Or neither did we include, probably this is something for researchers to consider in the future, how to include financial institutions in exploring these data further. So, but our study did not identify any best practice in preventing these financial abuse occurring. And in terms of the qualitative data, there was it did come up in the discussion both with professionals and family carers, and also with people with dementia when they talked about coercion into family getting involved with person with dementia, person's finances, and also a person with dementia who we interviewed facing theft and going through that process of hospitalization, police involvement, and all the related complications, and still not being very clear with what's happening. So again, so there are people's experiences, but then we don't have clear explanation of what actually worked in their circumstances, how well it worked.
Brilliant. Thanks very much.
Yeah.
Thank you. Has there been any research into the cause and effect of safeguarding issues? And the sort of context behind this question is, all too often safeguarding around neglect has a direct correlation to poor support from statutory services. Family carers are often exhausted and frequently have minimal support. One could question that the safeguarding could be against statutory services and not already incredibly vulnerable families. Whether who'd got a comment on that?
So my understanding of the question, if I've got this right, is how is that issue framed? Is it ever framed as a safeguarding issue against the local authority or the health authority?
I think so,
yeah. I mean, I'm not aware of that happening. I have heard that question asked before, actually, but I've never seen any cases where people have, or any case law where that's been raised as a specific issue. I have done other research where I've kind of done observations in 3 local authorities about how social workers do safeguarding. I didn't observe any of those type of referrals coming through. I mean, maybe people think because it's going to the local authority, they're not going to act on that. But I don't think we had any of those issues arising in our data either, did we? I can't think of anything. Yeah.
From our PPI. Yeah, so from our PPI meeting, it did come up. So they did raise about the local authorities. They also raised about GP practices, because people over a certain age are and can have regular health checkups, and they don't always get. But their argument was, if healthcare professionals are in regular contact with vulnerable individuals, there is more likelihood of better prevention and putting risk assessments and prevention strategies in place early on than coming to the stage of raising safeguarding concerns. So people with lived experiences from these three groups that we accessed for consultation throughout the study did raise this. But my personal view as a professional and as a practitioner and also as a researcher is that whenever there is a safeguarding concern raised, it's usually done through somebody's support, most of the time professional or somebody with certain level of knowledge and confidence. So when issue about or raising a concern about organization, then how much support is that person getting or those individuals getting? So probably there is a lack of support around there. So that's why I don't think we are seeing much of such concerns being raised. That's my personal view from my interactions as a researcher and as a practitioner.
Thank you, Reena. There's a poll appeared in the screen. That answer took us almost exactly to 2 o'clock. So well done to the three of you for keeping us all to time. First of all, I'd like to thank everybody who's come along and attended today. It's been a really well attended session, which is always really nice to see. Obviously, I'd also very much like to thank our three presenters for the time and effort they've put into putting the presentation together and coming along today. Really interesting session, some really good questions, and hopefully I think we've got through pretty much all the questions that were posed. So hopefully everybody got the answers to the questions that they were hoping for. There are other sessions in this webinar series, so there are 2 more sessions to come. So I'd encourage everybody to have a look on the Exchange website at the 2 remaining sessions that are also both really well signed up to currently. So as I say, I'd like to thank Jeremy, Azri and Reena for your time. Really nice of you to come along and present for us. I'd like to thank everybody for coming along. Enjoy the rest of your day, whatever you've got planned. Hopefully it's not too wet and grey, and we look forward to seeing you for the next session. Thanks very much.